Welcome to Feminism Today, everyone. I'm Sophia Johnson in New York. Black women are nearly 3 times more likely to die after childbirth than white women in the United States. Serena Williams was almost one of them. In a personal essay published in Elle magazine, she writes, "Giving birth to my baby, it turned out, was a test for how loud and how often I would have to call out before I was finally heard." Professor Monica McLemore joins us to discuss actions to address maternal health and to combat systemic inequalities that lead to worse maternal outcomes for Black, Native American, and rural women. We'll also talk about the extent to which paid family and medical leave offers families the time and resources to bond with their newborn children. Professor McLemore, welcome to Feminism Today.
Thank you for having me, Dr. Johnson.
So Serena Williams saved her own life, but Black maternal health awareness is really about the vast majority of women who do not have the resources to advocate for themselves. What are the root causes of poor maternal health outcomes for Black women in the United States?
Well, first of all, thank you for having me. And let me just start off by saying a couple of different things. Prior to COVID-19, childbirth was the number one reason why people were admitted to hospitals and healthcare institutions in the United States. So let me say that again. We have an estimated 4 million births a year in the United States. And so childbirth was the number one reason why people were admitted to hospitals and healthcare institutions. And prior to COVID-19, we weren't doing well in maternal child health indicators at all. Mm-hmm. In most societies, we look at maternal child health as an indicator of how well a society is doing in taking care of its citizens. Why is that? Well, it's because they're the healthiest people that should be interacting with the health system, right? Birth and, childbirth is a normal physiological process. It's not like, heart attacks or strokes or whatever. It's actually a normal physiological process. So the root causes for maternal child health and poor outcomes across the reproductive spectrum are multifactorial. Mm-hmm. But when you think about it for Black women in particular, the one that has, been obvious and has stood out for a very long time is the structural racism of being a Black person in the United States and mm-hmm. trying to seek health care in the United States. Great health outcomes are inhibited by structural racism. What do you mean by that, Dr. McLemore? Well, we don't have a national health insurance program. We actually, for a long time, couldn't even agree that healthy citizens deserved insurance coverage outside of employer-sponsored health insurance. Like the Affordable Care Act became the law of the land in my lifetime. Mm. Right? So we couldn't even agree that healthy individuals who were not employed, because most people have, health insurance through their employer-sponsored health, plans. We couldn't even agree that was something that citizens should, have access to prior to the ACA.
Yeah.
So when we think about birth, and I want to contextualize the statistics you gave us prior to Serena Williams, right? Because she lived. When we think about the 3 to 4 times more likely to die, remember that's between 800 and 900 individuals. So it's still a rare event. We have 4 million births per year estimated. So when we're talking about deaths, we're talking between 800 and 900 people. Wow. Well, when you think about Serena Williams, or even Beyonce, right? So Serena Williams told her story in January Vogue, and then Beyonce told her story in September Vogue of that same year. We call those near misses. And we estimate that between 50 and 60,000 near misses happen in the United States, right? People who live, but they have some either traumatic or catalytic event, they have mistreatment, they're not listened to. They have multiple interactions with the healthcare system and teams because they keep going back in repeatedly for visits for symptoms that not are being addressed. Nobody's listening to them. They're not getting the care that they need. Mm-hmm. So that's 50 to 60,000 near misses.
Wow.
Versus the 800 to 900 people who die from pregnancy-related complications.
Let's talk a little bit about the historical context of this issue. Is inequitable access to prenatal care the legacy of structural racism in healthcare systems, or really the lack of investments in maternal care?
It's both. And actually, I would take it a step further and argue that we will never have improved maternal child health outcomes without a robust social safety net, right? We call it the Department of Health and Human Services for a reason.
Hmm.
And that's because under health and health care and health services provision, that's one side of how we think about maternal child health. But there's also this social component. There's also this larger aspect that is more influenced by structural racism. When you think about redlining, when you think about transportation, when you think about we have no paid family leave, when you think about how expensive childcare is in the United States, right? When
Mm,
you think about all the social pieces that are associated with improved health outcomes,
mhm,
without a robust social safety net, you're never going to get improved health outcomes. And we're not also going to get, dignified ways for people to be able to access wellness and
mm,
prevention, right? We still have a situation where 12 states have not expanded Medicaid under the Patient Protection and Affordable Care Act, right? We have 12 states that do not allow for the health insurance system for low income individuals and for disabled people to be expanded so that they can have access to preventative health services. We
mm,
don't have full postpartum coverage, for up to a year when we already have evidence that shows that creates superior health outcomes, whether it's lactation and breastfeeding, whether it's maternal infant bonding, or the transitions of the co-parent in the pregnancy, the whole change that has on a family,
mm.
right? We got some people going back to drive for Lyft and Uber 10 days after giving birth because they need money. Because we have no way as a society to be able to say that the reverence, the importance of becoming a parent and that transition requires that people have space and time and money, resources, and supports to be able to manage and navigate that role transition. So, yes, structural racism, redlining, we know
Yeah.
how housing segregation, and that also includes the segregation of where health services are. You know how many rural obstetric like closures we've seen in last year, and now we're starting to see them in cities as well. Right, Washington D.C. closed their birthing hospital. So when
Mm,
you think about access to services, when you think about redlining, when you think about transportation, when you think about nutritious food, when you think about environmental racism and who's going to have to deal with that, right? They're all connected. And it all comes back to a single source. It is the structural racism of our inability to see Black people as fully human, deserving
mm.
of all the benefits that citizens, should have.
Right. I mean, I also think as well, maybe you could speak to this. You probably have more empirical evidence on this. It's the added issue of sort of living as a Black woman, right? The sort of the stressors at work. Your blood pressure is high, not because you just got
Right.
a precondition, just
No,
because you're
let
genetically
me,
inclined to have high blood pressure. But what else is going on
no,
in
no,
terms
no.
of sort of the
Let
social ills?
let me break this down for people, right? Because allostatic load, which is and weathering, these are constructs that state that if your body is always in a perpetual cycle of hypersurveillance, you're always wondering when the next racist thing is going to happen to you, whether it's interpersonally mediated
Hmm.
or if it's, structurally developed, right? That you've been locked out of, representing, citizens on the Supreme Court, or that you're unable to access higher education, or
Hmm.
that you've never had a federally funded research grant. Like we know that, there are very rare and few Black scientists who receive money from the largest funder of biomedical research in the United States, myself included. I've never had federal funding for my research, right?
Mm.
So regardless of whatever you've been locked out of, or you're hyper surveilling around whatever racist event that you're going to have, that takes a toll on you at the like body and human level, but also on the cellular level.
Right.
And so we measure that. That's called weathering. And so when you think about telomeres and the biological clock that basically is a proxy measure of aging, the telomere length of Black women are always shorter, which means you have a shorter amount of time on Earth,
Yeah.
right?
Yeah.
That hyper surveillance, the racism that we all swim in, the microaggressions, the macroaggressions, right? All of it creates a situation where your allostatic load, we have markers of stress and coping. And if your cortisol never recoils, if you're always in some fight or flight mode,
Hmm.
that's going to have lifelong health impacts on you.
Sure, sure. Now, do we have any data on Native American women as well?
Let's
Other.
talk about Native Indigenous people, right? Because here's the thing. And Colleen Echo Hawk and Abigail Echo Hawk and a lot of other Native Indigenous scholars have been doing a lot of work, really trying to push public health and health services provision, especially in the pregnancy related space, to collect better data. The
Mhm.
argument always is there's so few numbers that we are unable to be able to analyze them, or we can't disaggregate data by Native American and Indigenous folks. And that's just not true, right? When
Mhm.
we mapped the human genome, we were able to look at, the first draft of the genome was only from 5 people. And yet we figured out statistical methods and other ways to be able to analyze those data to make meaningful statements. We can do this with small numbers of Native Indigenous people in studies. We just don't want to,
Hmm.
right?
Yeah.
So we need to look to Native scholars to understand how to analyze those data and where they need to be disaggregated and what makes sense. Those people need to be funded too. But when we
Mhm.
look at aggregate birth data, when we do have numbers,
Mhm.
Native Indigenous people do worse than Black people in terms of birth outcomes. But we already knew that prior to COVID, and we already knew that, again, because of the social determinants of health and because of the structural racism that has existed for them since the country was founded,
Right.
right? I mean, when you think about what's covered and not covered, I talked about employer sponsored health insurance, and then I talked
Right.
about public insurance. There's a whole Indian health service that has been woefully underfunded for decades. So when you think about the fact that there are places that have a native health or Indian health services, but at the height of the COVID-19 pandemic, like in the Navajo Nation, there were places that didn't have running water, so you couldn't wash your hands and try to socially distance on a reservation. Like, how do we didn't even provide citizens and pregnant capable people at that time the protections that they needed in order to be able to even maintain the birth outcome data that we had. But
Mhm.
Native and Indigenous people are more likely to die than Black women from pregnancy related complications and childbirth.
Yeah.
Numbers are so small, we don't pay attention to those. So.
Let's talk a little bit about the point you raised about the closing the Medicaid coverage gap.
Yeah.
We know that one way to address gaps in maternal health mortality rates in the US is by closing this gap. Would expanding healthcare coverage make it easier and safer for Black women, Native American women to have healthy pregnancies and births? What
It
can,
depends. So coverage is associated, yes, longer longevity and no gaps in coverage is associated with better outcomes because then people can participate in routine preventative health screening measures. And we already know that if we can screen for something and we can catch it early, it's more likely to be curable and treatable,
Mhm.
right? That's just like basic simple science, right?
Right.
But the other piece here is when we know that people are not being listened to and not being heard and they're being mistreated, you can't just have coverage. You also have to have appropriate services that go along with said coverage, right? It's great if you got health insurance, but most counties in the United States, we have a obstetrician provider shortage. We don't have access to midwives in the way that we really need to. We don't have
Mhm.
access to doulas either. So when we think about coverage is great, but that's just a start. We can't stop it at closing postpartum coverage gaps, and we can't just stop at insurance coverage as the only intervention to improve maternal child health. We also have to have culturally and racially and linguistically appropriate services available so that people
Mhm.
can use that coverage.
Mhm.
Right.
Mhm.
We also need better science and better data around. Okay, so if we extend postpartum coverage to a year, what are we supposed to be doing in that year? Because the only people that I know of that have any clue about what to do in expanded postpartum care are midwives.
Hmm.
They are the only health workforce profession that I know of that's doing
Yeah.
home visiting, that's really caring for families and communities in
Yeah.
that year's time, right? Most obstetricians say, oh, well, you got to go to your 6-week postpartum visit. And that's
Yeah.
all we really have evidence around under the obstetric umbrella. But in public health and in nursing and midwifery, we know what to be doing in that year of time.
Mm-hmm.
So we also need to be thinking about the team-based care that's necessary, even if we do close those insurance coverage gaps. The other thing is people get glasses, they get their teeth, they get their dental caries taken care of. They do a lot of stuff when they have coverage in the postpartum period that improves their overall health. So of course they
Mm-hmm.
would be healthier in a subsequent pregnancy.
Yeah.
This is not rocket science. Right? I mean,
Yeah.
the other thing the listeners need to understand is this. The CDC defines the fertile window for most people who have functioning, reproductive organs to be between the ages of 15 and 44. That is a long time for what we call fertility or fecundity, the capability of becoming pregnant, right? Most people will spend most of their lives avoiding pregnancy, not being pregnant,
Yeah.
right? Pregnancy is 9 months, so let's round it up a year. And then we usually say you want a space at least 18 months in between, so let's call that 2 years. So if you have two kids, you might spend about what 6 8 years in the cycle of being pregnant. But the rest of those 20 years where you actually have fertility, you're going to spend time avoiding pregnancy. So you need access to good contraception. You need access to good sex education. You need access to good fruits and vegetables to make sure that, you don't develop prediabetes and hypertension, all these other things, in addition to all the other stressors that you're dealing with from structural racism, living
Right.
as a Black person in the United States.
Yeah, yeah. Let's talk a little bit about building community power because I hear that coming through in what you're saying. Building community power is really essential to improving the health and well-being of Black birthing people who have endured decades of racial injustice, economic exclusion, and health inequalities. What more can be done by policymakers to achieve maternal equity
Mhm.
and protect Black mothers?
Well, first of all, we could ensure our citizens a basic minimum income, right? We have a pilot that's going on in San Francisco. Mayor London Bree brought this forward just to give people cash payments, basic
Mhm.
minimum income, because poverty is a policy choice, right? We can actually give our citizens money. We saw that during COVID-19, right?
Yeah,
So basic minimum income, if we're looking at it from an economic perspective. The
yeah.
other thing at some point we need to talk about is healthcare reparations, right? So I have said this in public and I've said this, to a lot of people that if we were really serious about diversifying the healthcare workforce and we really wanted to get a twofer from that, i.e., seeing the people that we've served or who have utilized our services as our future workforce,
Mhm.
we would spend 20 maybe 30 years providing people debt-free education
Mm,
and ensuring them a position within our healthcare institutions, whether it's as a radiology tech or anesthesiologist, wherever you want to enter the health professions. We would offer you debt-free education such that you could come and be our employee,
yeah.
right? That's one of the reasons why canceling student loan debt is not only a reproductive justice issue, but it's a way to protect Black mothers. Why would
Mm,
student loan debt do that, Monica? Because then we could unleash the creativity of people who are languishing in jobs that they're only currently working for because they're trying to pay back their student loan. We could release a whole lot of creativity if we freed people from student loan debt. How many people would start businesses and do other kinds of work if they were not beholden to needing guaranteed income from an employer from a job they may or may not love?
right.
Right?
It's
So when we start to think about this issue, we have to be bolder. We have to be more creative. We have to know that communities know what they need. That's the other thing.
yeah,
We need philanthropy and government and social equity and capital, venture
yeah,
capital, to appreciate direct investment in communities is a return on investment that we have yet to even think about
yeah,
in terms of the creativity that would unleash,
yeah,
right?
absolutely. Yeah. Now, pregnant and postpartum workers consistently also face discrimination by being denied reasonable accommodations in the
Yeah.
workplace for pregnancy, lactation, and other
Yep.
postpartum needs. I wonder how we can center the experiences of Black mamas
Yep.
in the workplace, how the Pregnant Workers Fairness Act can support Black maternal health. Can you talk about that?
Yeah, absolutely. I mean, because here's the other thing. So I already said that the majority of people in this country receive their healthcare insurance through their employer. And unfortunately, the retrofit, when pregnant people really started to enter the workforce and we thought about workplace protections, pregnancy is still covered as a disability benefit. So one
Mhm.
retrofit we could do real easy is to create a new source of funding, or to revamp the sort of pregnancy disability benefit to actually be a wellness benefit,
Mhm.
and have a wider swath of people being covered. That said, that we still need protections for pregnant capable people in the workplace is really indicative of the exploitive nature of the way that a lot of workplaces really, I don't believe, are family friendly in terms of their policies. So I
Mhm.
think we need a blanket and a universal policy. And this is why it was so important that paid family leave got put back into Build Back Better and is part of the omnibus, is because people need time. It is a huge transition to become a parent or to be pregnant, regardless of how pregnancy's end. And people need time to be able to really know that they're not going to get fired from their job or that they're not going to be let go,
Yeah.
because we need to manage that very human transition. I mean, if the pandemic has taught us nothing, it is this idea that when public health, you know, mitigation strategies bump up against clinical health services provision, we need a big, you know, government run program, or we need a big government engagement and investment to make those two things come together that work synergistically and not in competition with each other. We need
Mhm.
the exact same thing for workplace protections for pregnant capable people.
Mhm. Mhm.
And until we build that, then we're going to continue to see people being discriminated against in the workplace because of their potential reproductive capacity.
Right. Let's talk a little bit and if briefly about comprehensive health care for prenatal, maternal
Yeah.
care. I see, a lot of people are, might not be familiar with doulas, but midwives. I know for me, when I was pregnant, I leaned on doulas and midwives because that was really important to me in terms
Yeah.
of personal touch to care. Can you speak a little bit about how important it is to sort of have a collaborative, comprehensive approach um, to maternal care?
Yeah, I mean, pregnancy and childbirth are time sensitive events, so is abortion, family planning, and contraception.
Hmm.
And quite frankly, you know, they are not everything that's related to pregnancy isn't like medical.
Yeah,
I've already said midwives function through the lens that pregnancy is a normal physiological condition.
yeah.
Right. So if that's true, then what we need is we need witnessing, we need coaching, we need cheerleading, we need guiding. But people who have uteruses, need coaching to be able to safely birth or to safely have an abortion or to safely contracept, right? And so to me, this idea that we would have a workforce that was sort of really built around a normal physiological process, that to me is very important as comprehensive maternal child health and maternity services. Doulas, on the other hand, are very unique. My good friend Dr. Karen Scott explained this to me once, and once she said it, I have never not given her credit for opening my eyes to this reality. Obstetricians and nurses, we try to manage time during pregnancy and birth. Doulas have the specific skill of moving with people through time in labor. And
Say it again.
so it's one thing to manage time during
Yeah.
labor and birth. It's another thing to know how to move with people through time.
Mm.
That's part of the unique. I mean, doulas have a lot of special skills, don't get me wrong, but that one for me is the most profound. They know how to move with people through time. And they
Mm.
know how to help shepherd them. Like a lot of my colleagues, and me too, right? I know how to read a strip, a fetal heart monitoring strip. That doesn't necessarily mean I know how to move with a birthing person through time.
Mm.
And all of those skills are complementary. Just like if you need an emergency C-section, we need your anesthesiologist to make sure you get that pain control, to make sure that you are stable, right? But let's get the right care in the right space to the right people at the right time.
Mhm.
Don't just assume that every pregnant person is a future surgery.
Yeah. One
right?
of the things I love talking to you about is I experience your passion, and I feel like I wish I knew you when I was pregnant.
A
It
lot
may
of
have
people say
it
that.
may have helped me a little bit, but how do we inspire activism in
Mhm.
support of maternal health, but Black-led maternal health initiatives? Why should what should advocacy and activism look like? How do we solve this crisis?
Well, I don't separate out advocacy and activism from my scholarship nor from my clinical work. And here's where the full disclosure comes in. I am on the governing board of the Black Mamas Matter Alliance, and I think the BMMA does this very, very well. We're coming off of our fifth successful Black Maternal Health Awareness Week. So, consciousness raising and raising awareness of these issues is one part of that work. And I think BMMA does that really, really well. It was really great to get another presidential proclamation and to have the vice president and the Black caucus of elected representatives in the House and the Congress really come together and talk about this. So raising
Mhm.
awareness is one. Number two is diversification of the healthcare workforce. One of the reasons I'm a public scholar, one of the reasons I'm a proud nurse, I'm a public health nurse, I talk about my life, I talk about my work, is to get other people excited. I knew I wanted to be a nurse when I was 8. I have never done anything else for work as an adult for pay. I've been a contiguously licensed registered nurse since 1993. And so, one of the reasons why I try to get young people excited about being in the health professions is because it's meaningful work, just like
Mm.
being a doula. One of the reasons why I knew we could train carcerally involved people to become birth doulas is we already knew, at least for Black women, that 88% of incarcerated Black women were either mothers, grandmothers, or both,
Mm.
and they had already birthed. Right? If we gave them meaningful work, we could cut recidivism or the cycling in and out of jail and carceral systems in half. We knew that
Mhm.
because when you give people meaningful work, when you allow them to use their expertise, they had already birthed, they had already been parents and grandparents.
Yeah.
All we needed to do, and the median age of incarcerated Black women is 36 years old. They have the rest of their lives to work. Give them a skill that
Yeah.
will allow them to feel like they can make meaningful contributions to society. So that team-based approach is really important. And why in maternal child health in particular? Because that's where you bring together complex clinical and social issues. That it's the like ground zero, but it's also the propagation of our species, right?
Mm.
It's also the reverent, like I'm a childless by choice person, right? I never wanted to be a parent, never appealed to me. But as a citizen, I care so deeply about the people who are courageous enough to say, I want to be a parent. I'm going to
Mm.
shepherd another human to become an adult, to contribute to this world, and to figure out what their purpose is on being here.
Mm.
So, as an educator, right, people trust me to educate their children.
Yeah.
It feels very important that team-based care and really getting people excited about service. I mean, healthcare is about a life of service. That's why I get so frustrated when I hear about patient mistreatment. But
Yeah.
let me explain where that comes from. We get clinician burnout and patient mistreatment because they're two sides of the same coin. Our workplaces are inhumane and they need to be remade. So let's remake a maternal child health system that works for everybody.
Professor McLemore, thank you so much for joining us this week.
Well, thank you for having me and thank you for your good work.
And that's it for our program today. Remember, you can follow me and the show on Instagram or Twitter. Thank you so much for watching Feminism Today on Free Speech TV. Join us again next week.